there, you have a better view there. And again, try to visualize the tip of the epiglottis. I think you are too deep already. Yeah, going into the vallecula, yes, a little bit more. Now, yeah. And now you can enter. Right, and yeah.
Is the tube meant to protrude through the...
A little bit. Yeah, it is. You see it here. If you enter, you have to look at the left side, because here we look only from above. This is a picture of the laryngoscope, and this is a picture of the Bonfils optic. Okay. You're over the vocal cords, fine.
Yeah.
Take the laryngoscope out. Push the tube down without moving the instrument. You have maybe use it here. It's a little tight. Yeah. Okay. Push the tube further. Excellent. Tube is going down, but the instrument must come back. And if you squeeze the tube too much, you push the instrument as well. Okay. Go out like this. And now check from the right side. No, better is from the right side. There you are.
Okay.
Yeah, excellent. Okay, next one. So. Oh, I'm supervised here. FBI is watching. I think the principle is simple in a way, but one has to have a little bit of practice. This is the smallest for neonates, up to 1.5 years. And this is a straight Hopkins, this is for other indications. And then we have 2. Yeah, this one is intermediate, this up to juveniles. You're inside, good enough. Don't move this anymore. Laryngoscope out. Laryngoscope out. Yeah, and now push the tube without pushing the instrument.
The tube?
The tube only. Yes, excellent. Not too deep. Good enough. Take out the instrument. This way, this way, this way. And now, there you are. There you are. The problem is, if you are not used to small children, you're moving too fast. Slow movement is in the end fast. It is, you see where you are and then push it down. Okay. You're too deep. Always try to see first the epiglottis. Oh. There is the epiglottis. Then move into the vallecula. Okay, that's fine. Now you have other way around. Yes. Now go straight down, and then with the tip, yes, under the epiglottis. And now look where you are. This is a picture of the fiber optic. You're over, good enough over the vocal cords. Stop. Take out the laryngoscope. And now push out down the tube. Yeah, it's okay. Push it a little bit more down. Go out, this way. Otherwise you... And then have a look from the right side. No. Never bend too much. Just going down. Turn a little bit to the left side. You're too deep. Going out, slowly. Turning to the left side. Not bending. It doesn't make it better. Just straight out. You see? It's easy. And very clear you are inside. Mm-hmm. Yeah. Well, this is a bigger Hopkins optic, a wonderful view, but this is for a certain indication. In children we would use a small one. It's just the difference. You have to overstretch the head, and then I can show you a few pictures. Then you can go straight through obstacles and so on, because you see I am still in the trachea, so I cannot perforate. Good enough. A little bit more the tube down, yes. Okay, good enough. Now come out with the instrument. Very good. And look from the right side where you are. Slowly, slowly going down. No, no, no. Not bending, not bending. Going down. Just there you are. Yeah. It's all going straight down. Bending is always a little bit too. Yeah. Very clear view. Yes. Yes. May I have a look here? Oh, where are my tubes? Suddenly they are gone. Oh, this is too. This is small. It's too small. I had several tubes. Maybe somebody took them away. I missed one tube here. Baby. Yes, this one as well. Well, this is the cuff tubes, which are very dangerous. It doesn't fit because the folds of the cuff, they are really working on the mucosa. But there must be another tube of mine.
So personally, till what size do you use? From what size?
8 years. Yes, most people now do it in every age, but it's not good. Yes, but this is storytelling. I will show it tomorrow. These cuff tubes,
If it's a surgery, is less than around.
there leaks blood and everything leaks through. And if you have an uncuffed tube, which must be proper size, and it's normally has an anterior little bit of leak, it keeps through the air, gets it out. No. We always use uncuffed tubes in tonsillectomies and so on. Yeah, some people in our country use LMA for tonsillectomies. You can do it only with very special ENT surgeons. A normal who is working around, it's not good. They aspirate a lot. And as you know, a little bit blood, child coughs it up, it's not a problem. But this is all problematized in the literature and in not bending too much. You're bending too much. The instrument is very ridiculous. Mm-hmm. No. Very slow movements, and always go from above till you see the tube. Yes, and then you go down. There it is. Just going slowly. No, never enter a curved instrument through a tube because you can perforate.
This lives on your pediatric difficult airway trolley, this instrument, doesn't it?
No, we have it in our we are a small hospital for pediatric operating rooms in one place, and there it stands, and everybody who says, "Oh, I have a difficult airway, please come." You have a battery. You have a battery. Squeeze it on. You go and see. No fiber optic instrument will be ready in 10 seconds, but this one does. Yeah. One has to have a little bit of practice, of course, but yeah.
And do you use CMAC video laryngoscope?
Yes, for the normal case, if you have the opportunity and the money, I must say, to have the CMAC for video laryngoscopes, you should. Okay. Now you can go out again because you're on the trachea. Move it this way, and now follow the tube going down. Yes, there you are. It's easy. Most people bend it too much and moving this way, which is not good. But before we continue, I want to show you the advantage of video laryngoscopy. With a normal laryngoscope, you don't see this. You see the vocal cords and you see, oh my goodness, there is something below. And then you see, oh, I rather should not intubate, I have help to do an endoscopy. And so you see simply more.
Yes.
Yeah. Okay. Kind of, yes, yeah. And now you go down, go under the epiglottis. Okay, you see the vocal cords, and now look here. You go through the vocal cords a little bit more. Here's still the vocal cord visible. Okay, that should be enough. Now take out the laryngoscope and push the tube down. Yeah. Okay. You're sure you're inside, and confirm that you're inside. Just going straight down to the right side a little bit more. No, follow the tube. There you see everything. You're inside.
So if you're doing this in a hurry and you don't have time to set up these...
You look through the ocular, but there you have to have a little bit of experience, because it moves against your expectations, you know. But okay.
What is the port? What's the use of that port?
For oxygen.
Leave the tube in.
Yeah, and because a flow of oxygen is always good. If you intubate, you need a little bit more time. If you're just at the vocal cords, your oxygen is going into the lung, is very helpful.
So you can connect it to your ear.
Yes, unfortunately we don't have it here. So, now, if you go down, what you do is what neonatologists do, doing this. There is a vocal. This is not good. It's very traumatic. Very traumatic. So this is very elegant. You enter, have a look. First here, you enter here. Now you see through the optical instrument, you're over the vocal cords. Good enough. Take out the laryngoscope. And now you push the tube without moving the instrument. Yeah, okay. That's good enough, not too deep. Now go out. Now go out and look from the side. There you are, yeah. You see slow movements, perfect view. The tube is in the right place. This is a video laryngoscopic view of the vocal cords, which you normally see with the normal laryngoscope as well. But if you look, you see more. There is a stenosis below. Yeah? So, you are warned, there's something wrong. I'm able to use this instrument, make a better diagnosis, or should I call for help? But one should not just intubate because you don't know what is there. And that's an advantage. And the other thing I want to show you is what neonatologists do. Oh yeah, here I have the entrance. This is for oxygen, and oxygen is flowing here. It's battery powered in an emergency. You can use it then. But I wanted to show you this. What is this? Looks awful, doesn't it? This is the epiglottis. And now if you go with this instrument here, the blood will occlude view. So this situation, I told before Dr. Dilip, we were in a workshop in a foreign country, I don't know where, can happen everywhere. And then it was in a hospital. Neonatologists screamed, get the people with the optical instrument, we are having trouble. What happened? Young child, 2.5 kilogram, firmly premature, severe pneumonia, they decided to intubate. And what do? Said, oh, child is quite good, we can well ventilate, nice oxygenated. You are second year, you must, the next one to train intubation. Come on. tried, failed, tried, failed. After the third time, a more experienced guy came. I said, oh, let me try. Always going down with the laryngoscope, pulling it back. You know, not thinking of that it's a particular situation or we might need an instrument to having a look. The experienced guy produced a cardiac arrest at the 5th attempt. Then the highest guy came, tried 5 times, and they were in the situation to lose a child. And then we too arrived with this instrument, Dilip with the tube, and we could see this. He is just taken from here. So we had a good view, and you think maybe we can enter here like in acute epiglottitis, and we were successful and really saved the child. But the people in medicine, you know that all, people are often not willing to learn. We said, we did it so often and forgot all the cases where it didn't go that well. So I'm trained to photograph these things that we can show it to other people. Because if you don't have picture, we can tell you a lot, you know. And this should not happen. The epiglottis is a very delicate organ, and this instrument here, if you use it as a lever, creates an incredible force, just incredible, and just catch the epiglottis is bad. Even in an older child, the same has happened here. It's not so dangerous because it's very easy to intubate it now with a larger Bonfils instrument, but just going down and just lifting up a little bit the epiglottis, and if it's a moderately difficult airway, why pushing so much? Why not using this instrument, just putting the tube down? So I think it's very important to have it and even make a diagnosis by vision. Okay, next one.
What situation is used? How different it is from the...
Oh, this is adult, but I have the little, this one for neonates. That's a Hopkins instrument, which is glass lenses. And you have an incredibly beautiful view. I only can show it. Oh, we need the camera. Without camera, no vision. Yeah, please hold it. Look what view you have. You can see the single hairs of my hand. And if this would not have been bleeding, then you could use this tube. Does it fit through here? Yeah.
Even we can railroad this tube through this.
Yeah, and then you have the tube. You're inside the tube, and then you can enter and see I'm still in the lumen, I'm still in the lumen. If you see this, sometimes you see this. Well, so how can you go through? You go and you move. You see I'm still in the lumen, very freshly. There I'm in the trachea again. And this for cysts and everything, very useful instrument. And of course for making a diagnosis. And if you have stridor, for instance, child with stridor will never give to the ward. You don't even need anesthesia. Just take and look first. And if you have this, see this, you think, deepen anesthesia a little bit, go inside. Nothing can happen. And I don't know if you remember what I showed in the morning, you know. This poor kid, 8 months old, the pleasure of its parents, you know. And people are going down, the tube it's tight, a smaller tube, pushing a little bit. Awful stridor, sending at the ward. That is not good. One needs to endoscope immediately, and then we really can save lives, as I said.
For diagnosis of very
Pardon me?
More so, this is useful for diagnosis and visualization of the structures rather than intuiting.
Yes, yes. You must know you can go straight. You cannot go that and make curves. That's too dangerous. But with this, it's okay.
Reroll your tube then, or is it just for the camera?
It goes into tubes, but the right tubes, they disappeared here. This is too long now, you know. But we can take this one off. Yeah. No, but still you can see you could go somewhere. No, we needed to shorten the tube there, but then it doesn't fit here. No, this. No, I cannot. But what I can show you is if you intubate with a cuff tube, what happens? You say, oh, this nice cuff tube. Look what it does. If you pull out the tube, you see what happens. It has a tension in itself. This is not innocuous. It's not. And if you put in the trachea, the folds are standing there and damaging the mucosa. I will show tomorrow the results. There's a study where they made biopsies after this intubation, you know. But I have a battery full of pictures how these tubes really did a lot of damage. And if you don't check with the instrument, you say, oh, we always use cuff tubes, we don't inflate them. But the uninflated might be worse than the moderately inflated, you know. Okay, who wants to try this again?
Say we don't have CMAP.
Yeah.
We have the instrument laryngoscope. As I said, the video laryngoscope. So if we use it direct, can we do direct? No, we don't have this.
You don't have this. You can use a normal laryngoscope.
We need to insert.
You don't need a video laryngoscope for using this instrument.
Or laparoscopic camera you can use.
You can tie any camera.
Insert it by looking through the camera.
Yes.
Cause more trauma. Or you need something to open the airway. Is that it?
The laryngoscope is good to create space for the instrument. Otherwise, in particular in children, you are touching the tonsils and you're putting all the bacteria down into the trachea. And what I can show here. What do you do in such a situation? You probably can intubate normally, fine. If you don't dare and you go with this instrument without using a laryngoscope, you poke everything everywhere and put down the bacteria. But we need the connector. But if you have such a situation, that's a classical indication for the Bonfils instrument, because you can slowly look around the curve and see, oh, the airway is open, and I go with the tube in and push the tube down, then everything is fine. So here's a connector holder, and you see the tip of the tube, so you know where you are with the tube. And now grab it up here. Here. Yeah.
That's why I said.
And now go straight down. There is the epiglottis, right? Under the epiglottis, you bend a little bit backward and enter. Bend a little bit backward. But your laryngoscope occludes part of the airway.
Come back. Bring the laryngoscope.
Better seeing that.
Come back.
You see better here.
Eyes true. So I go down.
Under the epiglottis. Yes, bending a little bit here. No, yeah, it's okay. Bending very careful movements. Yes, and now you're at the vocal cords. Push it down a little bit. Fine. You're good enough in the trachea. Take out the laryngoscope. Push down the tube. Maybe from above here. Yes, very good. You go out. And now you check from the side. Just going straight down. There you are. There you are. Yeah. This is a fry mask I was showing. And here's for fiber optic intubation. Little child, we want to treat you again. Now, there is this disc with an entrance. You want to go via the mouth. You do it here. You go inside here. It's for fiber optic intubation, but I can show. And there you see. You go with the fiber optic instrument through, and the other person is ventilating. So you all the time you can move very nicely. Now you go via the nostril. You know, via the nostril would be difficult now. Just turn the disc. Now you enter, and the nostril is right there, you know. And that's so unique, you can vent.
The nostril won't traumatize?
Pardon me?
If you go through the nostril, won't
You cannot do that because you cannot go around the curve. It's only for oral intubation, the Bonfils instrument. Okay.
fiber optic you get?
Yeah, that must be fiber optic. Do you want to try again? Where's the other tube? Oh, let's have this one.
What are the classical indications for this?
Pardon me?
What are the classical indications for?
If you cannot see the entrance of the larynx. I have some.
On routine laryngoscopy.
Yes, I will show you the indications. Now we are a little bit messed up here. I put this down here.
Laryngoscopy, you have to go this.
Laryngoscopy is important that you open the space, that you don't touch with this tube all the infected tonsils and everything. And this is a classical indication for this instrument, because you tried with a good laryngoscope, you cannot lift it up. And now you can do, if you don't have the instrument, using this. You go under it, you feel, you enter. Well, we did it all the time before we had the instruments, and normally one is successful, but there is a mortality. People are normally they're going inside, oh, it goes, and then they push too much and perforate the anterior wall, and that's mostly the death of the patient. And in particular, as more unexperienced people are, and as more afraid they are out of control then, you know. So there you see everything. You will show us?
We have to keep this tube outside.
Yes, this is a little bit too much out. It occludes your view. You have to push it back a little bit. So this is a good situation. You can see where the tip of the tube is.
Is this tip of the tube we have to keep outside this tip of the Bonfils, or
No. That would be dangerous because it will be sharp. So
the tip of the tube?
yes, now you see the tip is there protecting. Yeah,
We have to fix from
yeah. It's fixed good enough, I think. No, this Bonfils, yeah. Now you look for the epiglottis with the laryngoscope. You see what happened? What one should not do. You're lifting up the entire larynx. So normally you should not go down, but start here, going slowly, going slowly into the vallecula. A little bit more down. No, you're bending too much. Slowly down. No, just a little bit bending. Good view, and then you enter with the Bonfils. And you go down straight. And then you look at the left, no. Never go forward if you don't see where you are. You go down here. Where is the epiglottis? Maybe we change, wait a minute, we change the camera. Maybe the camera is out of focus again.
Why you are going above this? You're not going through the channel?
No, you come from the side. Through the channel, you would ruin the instrument, you know. Yeah.
But the curved blade will be better, or?
Wait a minute. No, that's okay. Start again. So, never go into something which is dark and move around. Go back immediately. Aim at the epiglottis so you don't do any damage, because going too deep and removing it, it's really damaging. Okay, another attempt. Yes, that's a perfect view. You go straight down, and now you look at this picture. No, you don't see. You go straight down. Where is the epiglottis? You have to. There is the epiglottis. You see the vocal cords. Now you can enter. You have a good view. Go over the vocal cords. Just a little bit more. You're bending too much. Oh, it's a delicate instrument. You're on the trachea now. Take out the laryngoscope. Push down the tube. Because you know you're in the trachea without using the instrument. Now you can go out. This way, this way, this way, this way. How deep is your tube? We don't know, so check from the outside. Never go if it's a curved instrument inside the tube, because you can...
Like fiber optic, we have not to.
Yeah, with fiber optic you can go up and down, not with this one. Now you go from the right side here, follow the tube, very slowly. No, you're on the left side, straight down. Put the tube a little bit to the side here. There you see. And you even can adapt the depth marker. This is 5, that's a little bit too deep. This is 4. In this case, 3 would be better.
3 okay.
Yes, it's a neonate. Yeah. So it's...
Instead to use this with CMAC, we can use normal scope use.
You can use normal laryngoscope. Yes, because you have the vision in this instrument, in the tip of the instrument.
We don't really need a video like
No, normal laryngoscope.
we have only...
Right, you even can... Oh, wait. How does it move out?
Without video there.
You even can use this one. But you have to use the light of this one.
Without light.
No, we put in the light again. I just wanted to show it. So this makes it far easier. So first, now look at this one. There you see where you are. That's a good approach. You go a little bit deeper because you have to be in the vallecula. Then you move it a little bit like this. And now you can enter easily. 1 minute. Okay. No. You must go down. Oh, you can see here, approaching right here. Go through it. Aki, could you follow? I have to.
Yes, I will.
Oh,
One of the biggest teaching hospitals.
fantastic. So, you have seen everything in pediatric anesthesia, isn't it?
But I have just a query that we are using audio equipment, visual equipment.
Yes.
Instead, see conventional laryngoscope to retract?
Sure, because the instruments have their own light. You can even use a laryngoscope without a light, because then you have to, the light is in your right hand.
Earlier when there is what they say it is only when there is situation the mouth opening is restricted.
Yes, if it's really restricted, it's just a little bit, you can,
Intended this.
yeah. But if you can open it a centimeter is good enough, and then you can still go in and see. You always control visually, and so that makes it so safe.
Because then this thing, the approach this thing discussed was you go laterally,
Yeah.
the intern says this thing, and then turn center. But today I'm seeing that we can use it when the mouth opening also. The central approach.
Yes, because you see exactly what you do. The other ideas are still where you had bad control. You know, if you're in particular neonates, the classical Miller, you see the epiglottis and they want to fix the epiglottis, which is traumatic. And then you go to the center and then don't see anything. You go blind. That's never go blind. We want to see. And well, they show you, look, you know. Now the optical instrument is sticking out. That's not good. You should be inside, you know. But the principle is very easy. But never go if you don't see. Yeah. If you don't see, you must go back. You must go back. Yeah. You are deep in the trachea with the instrument. Yeah. No, now you're out of the vocal cords. Yes. Now push the tube without the instrument. The problem is people are not used to push the tube. They grab the tube and the instrument and push it. So it's just a little bit of practice and then you can do it. You generally can use flexible about for everything, but it needs more training. You have to be very good with it. But the flexible is flexible. If you want to go through a mass and want to show I'm still inside, you have to have a rigid optical instrument within the tube. And the tip of this, well, this is for 200 kilogram people, but this is sharp. It should be inside the tube, so, but you have a wonderful view, you know. If you look here and you can go through and you manage to go through and then you see, and that's difficult with the fiber optic. And the worst is if you have a low obstruction in the trachea. It's often lethal if you just try to push with a flexible instrument, and the flexible instrument, oh, they're using it, bends. It bends, you know, and scratches on the side. And yes, and bleeding. If it's bleeding, you don't see anything anymore. You have to get it out. Yeah, it's very important. I mean, every industry wants to sell you the best thing you have, but it's expensive. And you must see, we started, or when I started, according to advice of an old professor, said, if you do pediatric anesthesia, begin with this. You see so much. And we started with this little, where is the little Hopkins lens? There it is. We started with this little lens. We didn't have more money for it. At that time it cost about German mark, it was maybe 1,500 at that time. 40 years ago, it's a lot of money. But how many things could we prevent with this? Showing that, giving early diagnosis and attracting people. And when we saw that, we went to Rotterdam in Holland. They were very advanced and they taught our pediatric ENT surgeon. Next step was ENT surgeon have to be in our hospital at least 1 day per week. And so it develops. And we developed this attitude. If there is a difficult situation like that, we need to make photographs. We have to show it to other people, you know. And in our hands, the airway is safe, so we can do it. And yeah, and Yeah, yeah. Yeah.
Excuse me, there's a small announcement. There's a lunch break after this. So you can all gather here at 1:30 after your lunch. And
Lunch
is
now.
of
Oh,
course,
yeah.
So the ground floor.
I'm thirsty now from talking. So we'll.
Water.
No, we are going for lunch now, yeah, isn't it?